Greetings, I am Chanique Salmon, a third-year Doctor of Pharmacy candidate from Orlando, Florida. Today my journal club presentation will be on the journal article titled Nivolumab versus Everolimus in Advanced Renal Cell Carcinoma. The objective of this study was to find the overall survival between Nivolumab treated patients versus Everolimus treated patients with renal cell carcinoma who had received previous treatment. The trial design consisted of 821 patients. It was randomized, a open label and phase 3 clinical trial. By open label, I am referring to that both researchers and patients were aware of the treatment given. The patients received a treatment of 3 milligrams of IV Nivolumab per kilogram every 2 weeks versus a 10 milligram oral Everolimus tablet once daily. The location was spread out between 146 sites in 24 countries, including North America, the United States. The inclusion criteria consisted of patients 18 years of age or older with a histologic confirmation of advanced or metastatic renal cell carcinoma with a clear cell component. Also, patients who received two previous regimens of anti-angiogenic therapy. Also, the inclusion criteria consisted of patients with no more than 3 total previous regimens of systemic therapy, included cytokines and cytotoxic chemotherapy drugs. The exclusion criteria for this study consisted of patients with metastasis to the central nervous system, or patients with previous treatment with an mTOR, that's mTOR inhibitor. mTOR stands for mammalian target of rapamycin inhibitor. The subjects were out of a total of 821 patients, where 619 were male and 202 were females. The primary endpoint of this trial consisted of the overall survival, which was defined as the time of randomization, which is a 1-to-1 ratio to the date of death of the patient if they progressed to that situation of passing away. The secondary endpoint consisted of the objective response rate and safety, progression-free survival, the association between the overall survival and tumor expression of PD-L1, and the incidence of adverse events. The follow-up was a minimum period of over 14 months, and the duration of this trial occurred between October 2012 and through March 2014. The races of the patients consisted of 88% white, 9% Asian, 1% black, and 3% others. Out of 821, 803 patients underwent randomization and were treated, where they were separated into groups of 406 in the Nivolumab group and 397 in the Everolimus group. Statistically, these groups were analyzed with a log rank test, where the comparison of the Nivolumab group with the Everolimus group with respect to overall survival and progression-free survival. The overall survival, progression-free survival, and the duration of response were estimated with the use of a Kaplan-Meier method. The survival was compared between the treatment groups with the use of the interim analysis monitoring feature of East software version 5.4, also known as CITEL, which is based on the LAN, DEMET, D-E-M-E-T-S, error spending function approach with an O'Brien-Fleming stopping boundary used to reject the null hypothesis while maintaining a two-sided overall alpha level of 0.05. The results of this trial consist of, it started as 821 patients, but 803 out of the 821 underwent randomization and were treated accordingly, where I explained the split up groups, where 406 in the Nivolumab group and 397 in the Everolimus group. The demographic and clinical characteristics of the patients were balanced between the treatment groups, and the majority of patients, which is like 72%, had received one previous treatment of anti-angiogenic therapy for advanced renal cell carcinoma. The primary endpoint, as stated before, was concerned with the overall survival, and as a result, the median overall survival was 25 months in the Nivolumab group and 19.6 months in the Everolimus group. Here is showing that the Nivolumab is more effective in treatment for patients with advanced stage renal cell carcinoma. The hazard ratio for death from any cause with a Nivolumab versus Everolimus was 0.73, with a 98.5% confidence interval, where with a range of 0.57 to 0.93, which met the pre-specified criterion for superiority. The secondary endpoint was concerned with the overall rate and safety, progression-free survival between both drugs. Now, as a result, the response rate was higher in Nivolumab than with Everolimus, with a 25% versus 5% odds ratio of 5.98. The median time to response was 3.5 months among the 103 patients with a response in the Nivolumab group, and 3.7 months among the 22 patients with a response in the Everolimus group, where, as you can see, the response to treatments was more faster or more in the Nivolumab group. Well, according to adverse events, the adverse events was graded by the National Cancer Institute Common Terminology Criteria for Adverse Events, where the most common event with Nivolumab was fatigue, a common drug adverse event, and the most common event with Everolimus was anemia. The author's conclusion consisted of, among the patients that were previously treated, the overall survival was longer and had fewer grade 3 or 4 adverse events occurred with the Nivolumab than with Everolimus. The strengths of this trial, I would state that it provides data for therapeutic effectiveness and safety, which will be beneficial for future studies, and the adverse events that occurred in both situations are seen in other medications like anemia and fatigue. However, I looked on Micromedics where Everolimus had a black box warning for immunosuppression in patients, so it should be carefully monitored with use, if used. And the strengths, another strength would be the long duration of treatment to observe the efficacy and quality of life of both treated patients. The weakness of this trial would be that I did some extensive research on the prevalence of renal cell carcinoma, where a lot of kidney cancer occurs in African Americans. However, in this case, we had 1% of the 821 patients were African Americans, where we had 88% of them were white. The question is, why is that? Is it pertaining to health disparities or health literacy? Because you're treating there was not enough information for a result of the treatment of the minority, which is the majority, yet you had 88% whites and 1% blacks. So the question is, how effective is it in the majority of patients that has kidney cancer? So the study proved that overall survival was increased with Nivolumab than with Everolimus. However, it did not address the majority of patients that had renal cell carcinoma, and that will be a good point to address in future studies with these type of drugs. Thank you.